Hello, everyone. Welcome to DSF's Listen and Learn educational series. This is the second webinar in the series, and we're excited everyone could join us today. I'd just like to take a moment to thank our educational sponsors who made this series possible, including Greenwich Biosciences, Neurelis, Zogenix, Encoded Therapeutics, and Stoke Therapeutics. I also would like to thank the American Epilepsy Society for their partnership with DSF to make this series CME accredited. I'll be sending emails following the session today with instructions for how to claim CME credit. Lastly, if you registered for this series, you should have received a link to a survey to assess your baseline knowledge of Gervais syndrome. Ideally, you would have taken this prior to accessing the webinar today. If you plan to participate in future sessions in this series, the survey is relevant to those as well. And following the close of the series in November, we'll be sending a follow-up survey to see how baseline knowledge has changed among participants in the series. Feel free at any time to drop a question into the chat box, or if you'd like to hold them to the end and ask yourself over video or audio, that's fine too. So today I want to introduce you to our speaker, Dr. Danielle Andrade. She's the medical director of the epilepsy program at the University Health Network at the University of Toronto. She's also the founder and director of the Krembil Neuroscience Adult Epilepsy Genetics Program, where she studies the causes and long-term outcomes of pediatric onset epilepsies. Dr. Andrade is also the director of the Epilepsy Transition Program, which is a collaboration with the Hospital for Sick Children that helps to promote a coordinated, smooth, and efficient transition from pediatric to adult health systems for patients with intractable epilepsy. Dr. Andrade also serves on DSF's medical advisory board, and we feel so lucky to have her as an expert in Dravet syndrome. Today, she'll be talking about Dravet syndrome in adult patients. And with that, I'll turn it over to you, Dr. Andrade. Thank you.
Thank you very much for this opportunity to share a little bit of our experience and a little bit of what's out there about adults with Dravet syndrome. I'm going to start sharing my screen. Okay, I hope everybody can see that. Okay, so here are my disclosures. And here are the learning objectives: to recognize clinical manifestations of adults with Dravet syndrome, to learn the best treatment strategies for adults with Dravet, and understand the different motor manifestations of adults with Dravet syndrome. I'll be talking briefly about the manifestations in infants and children, just in case there's anyone, any adult epileptologists who are not very familiar with this. And then I'll talk briefly about genetics, longevity, seizures, intellectual outcome, and motor disorders. So this in the, here's Dr. Dravet, Dr. Charlotte Dravet. Interest story, she was a student of Dr. Gastaut from the Lennox-Gastaut syndrome, Henri Gastaut, his first name was Henri. And she was observing the patients walking. So the patients at the time, they used to live in a residence, the patients with so-called Lennox-Gastaut or syndromes like that. And they would walk to a day program, which was closed, but she would see these patients walking, and she noticed that a few of them, as they were going through the difference between shadow and light that was caused by the sun shining through a lane of trees, those patients developed myoclonic jerks. So that's when she first picked up that there was something different about these patients. And the disease was described initially as severe myoclonic epilepsy of infancy. Of course, the disease doesn't cure itself as the patients grow older, so the name luckily was changed to Dravet syndrome. So these patients, usually they have a normal development until shortly after the seizure onset. They usually have prolonged febrile seizures, either GTCs or hemiconvulsive, but they are mostly normal between seizures. After a while, they start having afebrile seizures, which can be tonic-clonic, absences, focal unaware, which can be multifocal, myoclonic. There were some atypical cases where you didn't see myoclonus, and those were called SMAI borderland. But in general, seizures, the thought is that seizures were not completely controlled by antiepileptic medications, ketogenic diet, or neuromodulation. Finally, these patients develop learning disability evolving to moderate or severe. This is the knowledge we had, but more recently, in 2017, this group of neurologists got together to develop a set of recommendations to improve the diagnosis and management of Dravet syndrome, because it was noted that many other conditions which were not really Dravet were sometimes being diagnosed as Dravet. So they invited a group of panelists. I was one of them, representing the adult population with Dravet. And so their recommendations in terms of characteristics and clinical presentation are that the typical onset actually happens between 1 and 18 months. Recurrent generalized tonic-clonic or hemiconvulsive seizures are mandatory for diagnosis. These are often prolonged, but they may be shorter. Myoclonic seizures are typically seen between at the age of 2 years, rarely before the age of 2 years. Obtundation status, focal dyscognitive seizures, atypical absences are also typical, but again, they usually occur after the age of 2 years. And you'll see later that if they happen before that, might be a sign of a poor prognosis for intellectual development. Typical absences and epileptic spasms are atypical in patients with Dravet syndrome, so that's very important. Hyperthermia, which can be associated to vaccination, or just hyperthermia could be associated with hot baths or overexertion, or just a very hot day, so the environment temperature is too hot. So this can trigger seizures. Other triggers can include flashing lights, visual patterns, and even eating in some cases. Usually these patients have a normal development and neurological exam at the onset of seizures. The MRIs are usually normal, or they may show non-specific EEG findings. They may even show some hippocampal sclerosis later on, but at onset, usually normal. How the disease presents in older individuals that were not diagnosed as children. Usually these patients will still be having seizures, which include focal or generalized convulsive seizures. In many cases, they can have myoclonic focal, atypical absence, and tonic seizures. Recurrent status epilepticus and obtundation status are less frequent with time. Oops. Again, the hyperthermia, which triggers so many seizures during childhood, it's a bit less of a problem when these patients get older. Of course, they can have more seizures if they use sodium channel blockers. The intellectual disability is typically evident by 5 years of age. So between 18 months and 60 months, you can already tell that these patients have an intellectual disability. So as adults, this will be even more pronounced. You can see abnormalities on the neurological exam, which are typically evident by 3 to 4 years, and they include crouch gait, hypotonia, incoordination, and impaired dexterity. And the MRI, like I said, is typically normal, but sometimes it can show mild generalized atrophy or hippocampal sclerosis. What about the EEG? So before 2 years of age, the EEG might be diffusely slow or might even be normal. But usually after 2 years of age, The EEG is abnormal. Most of the times it will show slow waves. It can show intrictal epileptiform abnormalities. And here you have an example of myoclonic seizures on this EEG. And photoparoxysmal response is present in about half of the children before the age of 12. And after the age of 12, just 1/4 of patients will show that. Moving on, so I'll talk very briefly about the genetics of Dravet syndrome. So Dravet syndrome is caused in 80% of patients by an abnormality on the SCN1A gene. This gene is a sodium channel. And you can see here, this is the structure of the protein that is coded by the gene. And this protein has several transmembrane domains. So the green bar is the membrane. And there are several transmembrane domains. Some of them will form the pore of the channel, so through where the sodium molecules will travel. Some of these transmembrane domains contain the voltage-gated, the voltage receptors that will feel the voltage and open up. And we know that most patients with Dravet will have some form of nonsense mutation where you don't have the protein at all. But if you have a mutation, a missense mutation affecting this area or the area that encodes the actual channel, the pore of the channel, then you can have Dravet syndrome. You probably heard that SCN1A is also associated with other forms of epilepsy like GAPS plus, generalized epilepsy with febrile seizures plus, where you usually have missense mutations in other parts of the protein or in other parts of the gene that would cause an abnormality in other parts of the protein. So it's not so severely affected. So this is a very important figure that shows Dravet syndrome is a clinical diagnosis. And that's what you see here in this gray big circle. And you know that 80% of patients will have a mutation in the SCN1A gene, but SCN1A can also cause other diseases. And then you have a lot of other genes that mostly will cause a different form of epileptic encephalopathy, but a few patients might present as Dravet syndrome. Interestingly, as these patients grow older, sometimes you may see differences. For instance, patients with PCDH19, which is a condition that affects females and is associated with seizures and intellectual disability. Usually these girls will have clusters of febrile seizures when they are young. So it might very much resemble Dravet syndrome. But the difference is that they have way more psychiatric abnormalities. And as adults, 15% of them will develop schizophrenia, which is not something we see with patients with Dravet syndrome. So sometimes the very beginning of the syndrome might be difficult to properly characterize, but as the patients get older, it might be a bit easier. So how this condition evolves. In terms of longevity, we don't know much, mainly because there's not too many reports. So there's a case report of a patient that is 65 years old. My oldest patient passed away at the age of 53. The thing is, this condition was diagnosed in Dr. Dravet described the severe myoclonic epilepsy of infancy in 1978 in French. And the paper in English came a few years later. So many patients that started having seizures before 1978 or even 1980 were not diagnosed because just we didn't know about this condition here in North America. In terms of mortality, we know Dravet syndrome has a very high mortality, especially by SUDEP, which is 10, some papers will say even 15%. The other causes are status epilepticus, respiratory infections, and drowning. I'm sorry for the typo there. And the other problem that we have regarding the longevity of these patients is that sometimes we lose them to follow up. So again, the patient is old, the parents are even older, and then the parents become unavailable, and no one brings this patient to the clinics anymore. So that's unfortunately another reason why we don't know much about longevity of patients with Dravet. In terms of seizures, the adults will have less seizures, as I mentioned before. The period of active seizures usually starts to decrease after the age of 13 years. The myoclonic seizures and the atypical absences tend to decrease or even disappear in adults with Dravet syndrome. That's very important. The adults will be less sensitive to fever, although they can still have fever-induced seizures, but that's, you see, it becomes tricky to diagnose adults with Dravet because the parents might not remember the first seizure, and now they're not having febrile-induced seizures. They don't have the myoclonic seizures anymore, so it's a bit tricky. But hopefully, if you understand a bit more of the phenotype, you might be able to suspect that your patients, adult patients, might indeed have Dravet syndrome. The convulsive seizures also tend to decrease, and they tend to occur mainly during sleep. So even if it is a daytime nap, but usually they are restricted to sleep. Convulsive status epilepticus leading to ICU admission are much less common in adults, but they do sometimes will present periods of increased seizure activity, even if after a period of good seizure control. And sometimes you can't really identify any triggers. Finally, some adults with Dravet can become seizure-free, but it's not clear yet if we can stop their medication. So here's an example of the response to deep brain stimulation. So in 2006, we published this short note about patients who had DBS and their long-term outcome. And at the time, we didn't have their diagnosis yet. Later, we figure out that this patient had Dravet syndrome and this patient had Dravet syndrome. So a very different outcome for the same procedure. And then we had a closer look at them. And here you see the patient who didn't have a good outcome with DBS. So she had DBS implanted in the in the central median nucleus of the thalamus, didn't have any improvement or very mild. And then eventually she got more seizures, and then we did implantation into the anterior nucleus of the thalamus. She had a so-so response, but eventually her seizures dropped in frequency, gradually dropped in frequency, but this is over a period of 10 years. On the other hand, this patient had a significant response and immediate response to DBS. So he had an 80% reduction in the number of seizures just with DBS implantation. And then we started, and then eventually it went even down. And over the years, he has had less seizures. So this shows us two things. One is that DBS in the anterior nucleus might help. And the other thing is that, especially for people that think, well, if you leave there long enough, eventually the DBS will help. Maybe no, maybe this is just the natural course of the disease. We know these patients tend to have less seizures as they get older. So I'm a bit skeptical about the very long-term response to neurostimulation. I think sometimes it's just the natural history of the disease. Okay, in terms of treatment, this is the algorithm that was proposed in that consensus panel in 2017. At that time, fenfluramine and CBD were still in trial. So I think it was a phase 3 already. But anyways, first line definitely is sodium valproate and clobazam. second line, stripentol and topiramate. Third line, fenfluramine, CBD, levetiracetam, phenobarbital. And we should definitely avoid all these sodium channel inhibitors. And you may wonder, why should we avoid this if it is a sodium channel problem? The problem is that the sodium channel neurons that are mostly affected are those inhibitory neurons. So if we block more an inhibitory neuron, then we're going to have more seizures. So we have to be very careful to make the proper diagnosis and avoid all these medications here. In terms of fenfluramine and CBD, there might be a new consensus soon, and this might be bumped up. Who knows? We still are looking into that, but right now they are third line. Very important to stop the sodium channel. If you make a diagnosis in an adult and this adult has been receiving a sodium channel inhibitor drug, it's very important to stop, and might not be very easy. Patients may actually have a few more seizures when you're trying to do that. So you should try to bring the other medications in place. So the valproate, the clobazam, topiramate, stripentol, all that, and so you can start decreasing the sodium channel blocker. We did see improved attention and coordination in a few patients. And I have one patient where I was unable to stop the phenytoin. There is one case described in the literature about a patient who was on lamotrigine, and every time the lamotrigine was decreased or stopped, he would have more seizures again. So you do have the rare patient that doesn't read this these papers and doesn't know that he or she is not supposed to do better on these medications. But in general, if you stop the sodium channel inhibitors, the patients will do much better. One thing that is a bit tricky is starting stripentol in adults, and we just have this paper just came out last week actually in epilepsy. And the left part of this slide shows you the delay between the diagnosis and starting stripentol. So here you see the age of the patients, and we had patients being diagnosed at the age of 18, 20, or even more. So whenever they came to us as adults, they didn't have a diagnosis before, so we made the diagnosis. And look at this. In this case, it took more than 5 years to start the stripentol after the diagnosis. Most of the times, the parents were concerned that the patient was already taking too many medications, or they said, well, seizures now are much better than when he was a child or she was a child. What happens is that after a while, the parents, once they have the diagnosis, they start learning more about Dravet, and they see that their child is still at a high risk for SUDEP, and they decide eventually to look for a better treatment. So then we started stripentol in these adults, and we did the same modifications that are suggested for children. So we have to adjust valproate and clobazam. Our patients had side effects. Most of them have been already described with stripentol, so like gait difficulties, drowsiness, but they also had increased seizures, which is a bit atypical. They had decreased appetite, fatigue, mood problems, and drooling. With the increase in seizure frequency and some sleep problems that some patients also had, we wondered if there was something else going on. And we started measuring ammonia on our patients. And turns out that 77% of our patients, of our adult patients who had been started on stripentol, developed hyperammonemia. Well, we treated these cases with carnitine, and the side effects that were previously attributed to stripentol improved in most cases. So in some patients, we could even increase the dose of stripentol after starting carnitine. And then, of course, we are monitoring very closely the ammonia, the carnitine levels, as well as the other drugs. But that's important because it allows us to get a better seizure control, because we could increase this erythritol. Initially, the parents would say, well, might be working, erythritol might be working, but there's so many side effects, we can't go up on this medication. But once we started treating the hyperammonemia, we were actually able to go up on stiripentol and get an even better seizure control. Having said that, even with treatment with carnitine and all that, we couldn't go higher than 16 milligrams per kilogram per day in most patients. And the dose in children is 50 milligrams per kilogram per day. So there's something else in the adult metabolism that these patients cannot tolerate higher doses of stiripentol. So I'm going to talk about the other symptoms now, about adults with Dravet. So first one is intellectual disability. And the clear progress, we don't know very well, but we know that most adults will have a significant, I would say, moderate to severe intellectual disability. Both intellectual and motor skills can regress after status epilepticus. So that's very important to keep in mind. A few factors that have been thought to influence the intellectual outcome in the positive direction are an occipital alpha rhythm on the background in older patients, and perhaps a typical Dravet syndrome, or perhaps a wrong diagnosis. So when we read about those patients that do not have Dravet, we do not have intellectual disability, we always have to wonder if they actually had Dravet syndrome. Most of those descriptions were done in patients that did not have genetic testing, so we're always careful about that. In terms of things that we don't know if they can influence the intellectual outcome, is the type of SCN1A mutation, except for one I will talk on the next slide, the role of modifier genes, and finally the role of stimulation and rehabilitation. So perhaps a patient that has more rehabilitation may do better than someone else, but that's something that has not been systematically studied. In terms of things that can actually point into the direction of a poor intellectual outcome, we have the presence of focal seizures early on, the presence of status epilepticus early on, or a large number of status epilepticus, the early appearance of myoclonus and absences. Remember, I said usually myoclonus, absence, and focal seizures, they should appear after the age of 2 years. But if they come earlier, that might be a sign of poor intellectual outcome. Presence of hypotonia, ataxia, spasticity, and dyskinesia. The fact that you see interictal epileptiform discharges in the very first year of life is also a poor signal. And this SCN1A recurrent mutation, which was described in 2017 by a group of pediatric neurologists, including Ingrid Schaefer and Elaine Biro and Dr. Sadlier. And turns out that more recently it was found that this mutation is actually, it leads to a gain of function. So different from the most cases of SCN1A caused Dravet, which are loss of function, this particular one is a gain of function, and the patients have a condition that is even more severe than Dravet syndrome. So they have more severe seizures, more severe motor disabilities, more severe intellectual disabilities, is a different condition. The age at first observation of developmental delay. So again, remember, usually developmental delay is observed between 18 months and 60 months. If it's earlier than that, then again, a sign of poor intellectual outcome. Age of first afebrile seizure as well. And that's very important, the duration of contraindicated medication in the first 5 years of disease. So patients that were exposed to sodium channel blockers in the first 5 years of disease have a poor intellectual outcome compared to patients that were always treated properly without the sodium channel blockers. In terms of behavior, most of the adults with Dravet are calm, passive, and very affectionate. Autism is a problem. They do have autistic features, and perhaps they have depression. That's something that has not yet been systematically studied, but might be something that might affect their behavior as they get older. Another interesting thing that they have is obsessive behavior, and they like to hoard things. And I show this here because if a patient comes to the clinic without bringing his things from home, they will tend to collect these booklets in the waiting room, and they always like to have their things. So this is the example of one patient. He always come to the clinic with this bag of DVDs. The mother said that she has to fight him because he wants to have actually 2 bags of DVDs, and she allows just one. The other problems that they have are postural problems. So they develop anticolis very early. So all these patients, you can see that they have the flexed neck posture. The mother of one patient, the mother of this patient actually calls it the turtleneck. And she keeps saying, stretch your neck, stretch your neck. But it's something, it's a postural abnormality that all patients have actually very early. And then they have many other gait problems. So one of the hallmarks is the crouch gait, which is this where you have knees and hip. And that's very important. I remember this particular patient was the first patient that I made a diagnosis of Dravet syndrome. And I only made the diagnosis after I saw a video of crouch gait in patients with Dravet. And then I said, okay, that's what my patient has. And then I asked the mother, how was the first seizure? Do you remember? And she was able to tell me it was a seizure affecting just one side of his body. So that's very important clue to help you think of Dravet in adults. But they have other gait abnormalities. So here's a patient, you see she has a wide base, she's ataxic, she moves slowly. And if you listen to her,
turn around and show her how you walk the other way.
She turns and blocks.
Don't be sorry, you didn't do anything wrong. Oh.
And she has a cerebellar speech.
Oh.
Then you have this situation, which is called Pisa Syndrome, for obvious reasons. And again, wide base, slow. And here, I want you to see the anticolis as well as the speech, the cerebellar speech.
Next picture for me. Okay, last one. So go back in the room. Yeah. Thank you. Okay, so just go back in the room. And then I'll see you on your side. Sure. Thank you. Yeah.
So here you see again the abnormal gait, the chin to the chest, which is an even further evolution from the anticolis. And this is camptocormia, which is a further evolution from that. And this is the older patient that we had, and she has the significant camptocormia. So all these are Parkinsonian manifestations. And our patients have small steps, they turn on block, they have postural instability, Pisa syndrome, rigidity, bradykinesia, hoarding behavior, anticolis, and camptocormia. The only thing they don't have is the tremor, which sometimes they do, but it's a valproic acid tremor, not a Parkinsonian tremor. given that they have these Parkinsonian manifestations, we treated a few patients with levodopa, and it was perhaps too late for some of the patients, but we did notice some change. So for instance, this is the patient with Pisa Syndrome, and when she was here before the levodopa, she really couldn't walk much. She came on a wheelchair and she stood up for us, but she wasn't really walking. And as you saw, after the levodopa, she was walking. The other thing is here, you can see her face. Here you cannot. So her chest, chin to the chest was more evident here. Here's a little bit better. So it did help a little bit, not as much as we wanted. Perhaps if we had started earlier in a few patients, would have had a better outcome. So of course, the next question we asked is if this was a result of the disease or the treatment. And it's really difficult to know because these patients have so many medications from such an early age. So we compared patients with Dravet to patients with Lennox-Gastaut syndrome, because those are also a group of patients that have severe epilepsy and they take a large number of anti-epileptic medications from an early age. And what we saw was that the anticholis and the Parkinsonian gait was more prevalent in patients with Dravet syndrome. So not so much in patients with Lennox-Gastaut, but Dravet actually had a significant anticholis and Parkinsonian gait. So in conclusion, adults with Dravet syndrome tend to have less seizures and they are less sensitive to heat. Most adults will have moderate to severe intellectual disability. It is unclear if the intellectual disability is simply a result of the gap when they are growing up and they're not acquiring new knowledge, or if there is a progressive intellectual decline as they get older. The motor problems appear to be progressive. The management of ammonia may allow further increases stiripentol and better seizure control. And I'll stop here and I'll be happy to take questions if there are any.
Thank you, Dr. Andrade. We did actually already have a question pop into the chat. And so it's from Jill Safar asking, if not Gervais, what else would they be diagnosed with, and how would you distinguish without a medical history? And so this came in when you were talking about that you had, heavily used the gait abnormality to help guide you towards Gervais with that patient.
Yeah. So there are other developmental and epileptic encephalopathies that can lead to these gait abnormalities. But as we showed with the example of Lennox-Gastaut, 2 patients in the Lennox-Gastaut had a bit of Parkinsonian gait or anticholis, but overall the majority of them don't. There are many epileptic encephalopathies, and in adults it's really tricky to diagnose because they will have a phenotype that is different from what is described in the literature, because most of the literature is in children. So in fact, sometimes your best bet will be to do a genetic test.
Anybody else, if you have a question and you want to pipe in, you can unmute yourself.
Yeah, I have a question here. This is Jamie McGregor. I'm with Sogenics up in Minnesota. And how do you, I blinked and missed the part about the differentiation between Dravet and Lennox-Gastaut in the movement, in the abnormal movement part. Can you cover that one more time? That's a really good point, and I think it will help a lot of adult doctors kind of differentiate between the two.
Yeah, so the Dravet patients, they have more Parkinsonian features. So especially the anticholis, which is the neck going forward, and the Parkinsonian gait, which is a slow gait with small steps. They tend to turn en bloc and they have postural instability. So if you do the pole test, they can't keep their balance. They will step back a few steps. So those are the main things that may help you differentiate between Dravet case and another form of epileptic encephalopathy.
That's fantastic. Thank you for clarifying that.
I actually had a quick question for you about the stiripentol and that increased ammonia. So this was that study was mostly looking at adults that had started onto stiripentol, correct?
Yes.
What would your recommendations be then for patients who maybe have started stiripentol as a child or an adolescent, and as they age, is that something that if they've been on stiripentol for a long time and haven't had issues, that as they age should be additionally really closely monitored?
So if they're doing well, you probably don't need so much of a close monitoring. But if they are still having seizures and you want to increase the dose, I would suggest monitor ammonia and carnitine. I mean, the carnitine is just so you know how much you have to replenish, but monitor the ammonia. Dr. Rima Abu described patients taking stiripentol. She was part of one of the big trials, or all of the big trials. But one of them, they had patients that were properly diagnosed as children, and they continued taking stiripentol. And they also couldn't take as much as the other children, but I think they were taking more than what we were able to get.
Okay. Thank you for that. We had another question come in again from Jill asking, what would be the best approach when working with physicians who claim they have no Dravet patients when maybe in fact they actually do?
That's a very good question. I think you mean how to convince that your colleague or the physician you're working with might have Dravet patients. I think if they have a patient that has intellectual disability, seizures that are intractable, but better than when the patient was a child, and motor dysfunction, this patient deserves further investigation. In fact, I think that every patient that has an epilepsy which is not yet diagnosed should have a better investigation in terms of diagnostic tests. What I say is that most of our adult patients, they did have the $1 million workup when they were in the pediatric care. The problem is that at that time, what was available was karyotype, fish, expansion for X-linked mental retardation. So you really didn't have the next generation sequencing tests, that technology that we use today. So this patient should be reinvestigated. Any patient that is still having seizures and you don't know the cause should be reinvestigated.
Thank you.
You're welcome.
Have you had, I don't know what things look like in Canada versus the US and what the differences are. I know sometimes getting that expanded, particularly genetic workup, can be a little bit, there's additional barriers for adults than say for children, especially with expansion of programs like Behind the Seizure, where they're giving free genetic testing to patients up to age 8. Have you seen that be an issue for adults to get access to the expanded testing?
No, so far it's not been a problem here. I mean, if someone asks why would you want to know the genetic diagnosis in an adult, what else can you do? There's several things you can do. For first thing is put the patient in the right medication. So if it is a Dravet patient that is taking carbamazepine, that's bad medicine. That's bad practice. the other thing is many of these adult patients now have siblings who are of childbearing age, and they are, of course, concerned if they could have a child with the same problem as their sister or brother. So knowing the genetic diagnosis and doing the proper genetic counseling is something very important. Not to mention that the quality of life of parents improves once they know what the patient has. And there are studies about this. So they, even though it's a bittersweet, because Dravet syndrome is such a heavy diagnosis, but at least they know it is a genetic mutation. It's not a glass of wine that the mother had during pregnancy or something like that, because unfortunately they do blame themselves for things that are not at all related to the condition.
Great, thank you. I think that's really important points to make. I think a diagnosis at any age is huge for patients and families.
Yes, absolutely.
If no one else has any additional questions for Dr. Andrade, I think that we can go ahead and call the session for today. I'm so pleased that everyone was able to join. Like I said, if you need to claim CME credit for this, I'll be sending an email with instructions and a link. If for some reason you don't get that email, you can reach out to me. It's veronica@gervaisfoundation.org. But look for that by this afternoon. And thank you again to Dr. Andrade for being here and for your really knowledgeable talk.
Thank you so much. And if you can, please fill out the questionnaire. That's very important for us. Okay, thank you very much. Bye.
Thank you.
Thank you.